Good afternoon, everybody. Welcome to Grand Rounds today. Thanks to Mary Greeley and our other supporters of the CME activities here for the nutritional support. Today, it's my pleasure to introduce Dr. Ellen Kitchell. Dr. Kitchell is an infectious disease specialist at the University of Texas Southwestern, where she's an associate professor in the Department of Infectious Disease and Internal Medicine. She's also the director of the HIV fellowship program at University of Texas Southwestern. During her tenure there, she has been the recipient of multiple honors and awards, including being the Physician of the Year last year at Parkland. If her name sounds somewhat familiar, that's because she is a graduate of Ames High. Her mother is Mary Kitchell, who is a board member, the board of directors at MGMC, and her father is Dr. Mike Kitchell, neurologist and a longtime member of the medical staff. And the CME committee is very appreciative of her accepting our invitation today to shower us with some infectious disease pearls. And please join me in welcoming Ames' own Ellen Kitchell.
Yeah, thank you so much for the introduction. Can everybody hear me and see my slides? And it doesn't look weird on the presenter view? Okay, let me know if they don't look good. But I am also extremely humbled to be invited to this lecture series. Ames, McFarland, and Mary Greeley literally nurtured me from the cradle into who I am today as a healer. Of course, my parents taught me the importance of a life of service and tolerated my intellectual curiosities. And, amazing teams at McFarland and Mary Greeley all taught me from the beginning how to care for patients expertly and with compassion. And so I owe so much to all of you. In my humble opinion, the doctors in Iowa are the best in the country. So I was a little like, oh, what am I going to pick to talk about that you're not going to know everything about? But today I decided to pick up do some cases of some things that we're seeing right now in Texas, which unfortunately you may see more of in the next few months with everybody moving around and the weather changing and everything. So we'll go into the cases now. All right. So this is a case of pretty recently here in Texas. And this is a gentleman, no past medical history, otherwise pretty healthy. And he presented with a 3-day history of right eye redness and discomfort and also a watery discharge. He doesn't have any vision blurring, no fever or chills, no nasal congestion, cough, or any other symptoms. And on exam that day, he was afebrile, normal oxygenation, and this is what his eye looked like. Not very much discharge, just kind of this watery discharge, but not very thick. So thinking about conjunctivitis, there's different types of conjunctivitis that are related to different pathogens. And a lot of times we reach for antibiotics very quickly for these patients, but that's not always the right thing to do. The left side of the slide shows that somebody with bacterial conjunctivitis. And that one usually looks like, whenever I think of a bacterial conjunctivitis, I think of just like a goopy exudate, really thick, purulent discharge, and the eye is often stuck shut. So that's somebody with a bacterial conjunctivitis. And the causes that would most commonly in adults are Staph aureus. In children, strep pneumo, H. flu, and moraxella are more common, and gonorrhea chlamydia can also cause this. And contrast to that, there's allergic conjunctivitis when there's a lot of pollen in the air. It really has a very similar to presentation to viral infection. It's often bilateral, itching, and the hallmark is that it's worse with rubbing. But based on what this patient that we saw today recently, symptoms and his exam, you're really thinking about viral pathogens. And so the most common viral pathogens that cause conjunctivitis are adenovirus and enterovirus. And more rarely, there's HSV, VZV, some measles, mumps, rubella, and somebody who hasn't been vaccinated, somebody with a history of Zika virus, you're thinking about that. And there's some other viral infections that also can cause this, but adenovirus and enterovirus are the most common. And so are there any other viruses or any questions you want to ask? Remember, this disease is very highly contagious. So when you get further history about the patient, you always want to ask about sick contacts when you have somebody with an infectious disease. He does not have any human sick contacts, but he is a dairy farmer and he has direct exposure to cows that are not doing well. They have all sorts of symptoms of decreased milk production, reduced appetite, fever, and dehydration. And the farm that he's working at is not the only area to also have sick cows. He does wear gloves when working with the cows, but he doesn't wear any respiratory or eye protection. And significantly also, he does not have any exposure to sick or dead wild birds, poultry, or other animals. And so we had really good communication here in Texas. And so we already knew what was happening with the cows. So, the human doctors talked to the animal doctors and they said, we are having an outbreak of flu in our cows. So the physicians tested for influenza A, and they did a conjunctival swab and a nasopharyngeal swab and sent it off for DNA testing, and it was positive for influenza. To follow up on the patient, they did recommend isolation and treated him with oral oseltamivir for 5 days, both for the patient, and then they also gave the same treatment for all of the patient's household contacts. Over the next day, and this is actually pretty typical of most cases of viral conjunctivitis, it did actually spread to the other eye, just with the redness, the drainage. But then over the next few days, he's completely all better and he feels fine, and none of the household contacts remained well. So in addition to sending it off just for the testing to find out what pathogen this was, they also sent it off for complete genetic sequencing to find out what was going on with this influenza. And if you remember way back to, microbiology, this is the structure from Wikipedia, a picture of influenza. And if you remember, there's two proteins that are really important. There's the hemagglutinin protein, and that's the purple little things that you see right there. And that's the receptor that influenza binds to get into our cells, like in our nose or eyes or in our respiratory tract. And then at the end, like it does all this stuff inside the cell and then gets released from the cell and it kind of chops off. And that's the neuraminidase protein, or NA. And so there's all these different types of influenza A, and they have an H number. There's like several different subtypes of hemagglutinin that they kind of mix and match with certain numbers of the neuraminidase protein. So you may have heard of like H1N1. That was swine flu back in 2009. But there's all sorts of like H3 and 5 and all those sorts of things. So this one turned out to be an H5N1 virus. And they found that the virus that was in this patient was very closely related to the virus that was found in the cattle and also in wild birds that were seen in Texas. And concerningly, what they saw was, yet again, you saw a patient where it was in one animal and then it changed that receptor protein of the hemagglutinin receptor, and it was able to adapt to a new host, a mammalian host, in this case, a cow, and then from the cow to the human. Good news, looking at the genetic analysis, when they sequenced it, they didn't see any changes in the virus that would show reduced susceptibility to antiviral medications. And the other good news out of that is that the H protein was very similar to some vaccine candidates that we have on the shelf. So we have something that's ready to go for vaccines. So you probably have seen all the news coming out of Texas. I mean, there's so much other stuff going on. So if you missed it, it's okay. But everybody's kind of freaking out. And why is that? And so this is the first time that we've seen. We know that there is virus that goes from bird to human and human to human, but this is now a cow to human transmission of influenza A virus. And so this virus has adapted, just made a little change in its protein, and it's now able to spread into the human population. And then when it spreads into the human population, of course, it can turn into a very big outbreak for people who weren't necessarily exposed to cows closely. Right now, the cases that we are seeing are people who are exposed to infected animals or contaminated materials. There's a super high amount of virus in raw cow's milk, which, if it's pasteurized, you're totally fine. It kills the virus, but there's kind of a trend on the internet right now to drink raw cow's milk, so not recommended at this time. And the concerning thing here is there is a multi-state outbreak in dairy cows. And if you can see from this map here, this is the confirmed cases in dairy cows in the United States. And as you can see, we have it in Texas, but also there's a lot in Iowa. It's also, if you put the pictures of, they do tracking of wild birds, it's pretty widespread across the United States. And there's also sporadic outbreaks in the poultry flocks, which again is that there's quite a few poultry flocks in Iowa that are affected by this infection. So unfortunately, I really think you're going to see more cases. So what is this virus? And it sounds really scary because it's called highly pathogenic avian influenza, H5N1 strain. So actually, highly pathogenic actually refers to its effect on birds. So we don't know as much what it does in humans. The first case was discovered in the 1990s in China, and then total, this is still a little behind in the total, but it's about 900 cases overall worldwide as of July 6th. Of the cases, 52% of them have been fatal. Personally, from my opinion, I think this is a very underreported disease, so the fatality rate may not be as high. But that is a very, very concerning high mortality rate, of course. Nearly all of the cases so far had reported recent exposure to poultry, but now we have these new cases with exposure to dairy cattle. And the total now is up to 9 human cases in the United States ever, with the first case occurring in 2022 after poultry. And now we have these dairy cattle. And then last week into this weekend, we had more cases in Colorado with exposure to poultry. And that was really kind of a sad case to read about because this outbreak in Colorado was in a setting where the workers were working at like 104-degree heat, and they had these fans, and it was just blowing the PPE off people's faces, and it was just, as we call in Texas, a recipe for disaster. So very concerning. So there actually is some good news, if there can be any, about highly pathogenic avian influenza. And one of the good news is that we don't have to develop a new diagnostic test. You can test for influenza with the same influenza test that we have. So if those of you who are aware of doing influenza testing, there is the best test is the RT-PCR test. Usually takes about a day to come back. There is also something called a respiratory viral panel, which will test about for like 15 to 20 viruses. They don't like us doing it at my county hospital because it's pretty expensive, several $100s, and really doesn't give you a lot of information. Like it'll say like, oh, they have rhinovirus. You're not going to do anything about it, but you could do something about flu or COVID. Rapid testing, really remember, it's only about 70% sensitive for any type of influenza. And if you have somebody that you have a high suspicion that they have influenza, go ahead and treat. And then you can always do these more sensitive tests and stop the treatment later. This test is not going to differentiate between the new avian flu versus influenza A, but that's good information to use. And the treatment is the same. As I said, there's no evidence of resistance to our typical flu drugs. The one is currently most recommended is oseltamivir, 75 milligrams twice a day for 5 days. And I looked at the prices at the Hy-Vee in Ames, and it's about $20. So if your patient doesn't have insurance, the other flu drugs that you may not be as familiar with, they're more expensive, but may have an indication in certain instances, like an IV medication, and then there's a one long-acting dose, but that's a little more expensive. The treatments with influenza, as with any viral infection, it's just if it crosses your mind and the patient is sick, always start the medication first. Don't wait on the results, especially don't trust that rapid test to rule out influenza. And as compared to seasonal influenza, it's actually recommended to treat all patients that have either suspected or proven avian influenza because we just don't have enough information about how its clinical course is going to be with this new change of the virus, and it's spreading more rapidly. So these are not fantastic drugs, I have to admit, for even seasonal influenza. It usually reduces symptoms by 1 day. It may help cut down on hospitalizations or benefit for hospitalized patients, but it is not well documented that it's this wonder drug. But it is the recommended treatment to treat with a neuraminidase inhibitor. And what about vaccinations? So unlike the treatment for seasonal influenza, the vaccination for influenza makes huge effects on mortality, transmission, hospitalizations, and death. And if that isn't enough, my boss is doing some really interesting work showing that history of influenza infection may be associated with some neurodegenerative disorders. So if death and protecting your loved ones is not enough to prevent dementia is also a good thing. I like the messaging that they're doing that, a flu vaccine is not 100% protective of influenza, but it can change it from killing you to minor inconvenience for a few days. Unfortunately, the seasonal influenza vaccine we're going to be giving out in a couple of weeks does not target the strain of influenza, and you need a special vaccine. If you were around in 2009 and dealt with swine flu, then you know that in the middle of the season we had to roll out a new vaccine. They do have, as I mentioned, they have vaccine candidates that are available and are ready to go, and they're going to have them available. They're not available now, but they should be available probably in the fall. Whether they're going to recommend rolling it out to all patients or selected patients or just high-risk patients, or maybe this will all blow over and nothing will happen, we don't know yet. So keep your ears peeled. And Moderna, the group that made the mRNA vaccine for COVID, also recently was contracted to develop an mRNA vaccine, which gives a faster turnaround time. Unfortunately, that is not anywhere near ready to go, and that will be available probably in 2025. This case really illustrated the importance of One Health approach, and it's really, we need to understand what's going on with the health of animals in particular, our shared environment, what's going on with the animals are getting sick, and then the viruses are passing back and forth between us. And so we really need to do a good job about talking to our veterinary colleagues, and I'm preaching to the choir in Iowa. You really do a great job of doing that. So that's the case of avian influenza from a cow. We'll go on to the next case, and if we want, we can do questions at the end. So this is a case that is unfortunately very common in Dallas, Texas, and this was a gentleman in my clinic. He has a history of HIV, and he's on this medication, and he's doing, all those labs mean that he's doing really, really well. His immune system is basically normal as compared to somebody who does not have HIV. And he comes in with a rash, headache, photophobia, redness and pain on the right eye, and vision loss. And this is a picture of his eye, and this is a picture of the rash. It is on the palms and the soles, and it is also on the chest. And since we see multiple cases a week like this, we knew what labs to order. So he had a normal CBC. His liver function tests were a little bit elevated, especially the alkaline phosphatase, which is common in this infection. His gonorrhea and chlamydia tests are negative. But then, of course, we tested for syphilis. So treponema pallidum CIA test was positive, and his RPR is 1 to 64. So this is the diagnosis of syphilis. But the important thing now is to go and figure out what kind of syphilis does he have, and we'll get into that in a minute. And so you may be like, why are you talking about syphilis, Ellen? Because when I moved to Dallas, Texas, and I started working in the HIV clinic, I saw as many cases in my clinic that I take care of, as were in Iowa. I saw in about 2 weeks, we had about as many cases in Iowa as you have had in a year. That was back in 2005. Now our syphilis cases continue to increase, and this is Dallas County data showing that we have 3,000 cases a year. But what's happening in Iowa? This is not a good curve to see. So you've increased your cases by 300% in the past. This is like 3 or 4 years. So the numbers are just going up, up, up. So you are also going to see syphilis too. So, and unfortunately, you're not seeing in just the traditional risk factor groups. It was really, maybe 10, 15 years ago, it was really very much affecting men who have sex with men, but it has spread from that group. And unfortunately, one of the groups it's spread to is babies. And there's a really high rate of congenital syphilis in the United States. And unfortunately, it has very devastating consequences for babies, including pregnancy loss, low birth weight, those weird skeletal abnormalities you learned about in med school, like Hutchinson's sign, things like that, hearing loss, blindness, and neurologic symptoms. So we need to be testing and being very aggressive at treating this. So what happens in somebody with syphilis? Remember, kind of going back to learning about this in medical school, the different stages of untreated syphilis. One thing that's important to know is that invasion of syphilis into the central nervous system occurs very early on in infection, and you can get eye disease and hearing loss at any stage during syphilis. So you can have it at the beginning and you can have it at the very, very end. So it can happen at any time. So you want to be screening for that because the treatment is different. So primary, if you remember, was just a chancre and usually painless. Usually you can't, your antibody tests, your lab tests are not going to be positive unless you have a, dark field microscope in your closet or something. Then we usually just recognize it and treat it. Secondary syphilis usually presents with a rash. The rash can look like anything. The classic is the macular papular rash that I just showed you a few minutes ago, but it can look like anything. It can be painful. It can do anything. So just always have it on your differential diagnosis. It can also cause fever, lymphadenopathy, hair loss is one thing you can get, and hepatitis. And then latent just means no symptoms. So if you do lab tests on somebody and they just have a positive lab result and no symptoms, then that's called latent syphilis. And then tertiary syphilis, again, they think that you they sound like ancient history, aortitis, dementia, gummas. They get these big skeletal lesions that erode through the skin, and tabes dorsalis, which this is so weird, and I have seen all of these in Dallas, Texas, unfortunately. So that it's somebody who hasn't had syphilis treated for a long time, usually 10 years or so, but it can advance quicker in somebody with low immune system. So how do you diagnose syphilis? They changed the way that you diagnose syphilis a few years ago, and they now call it the reverse algorithm, but maybe some of the younger clinicians don't know that. But what you're supposed to do now is look at treponemal-specific antibodies, because we used to use the non-treponemal antibodies, and then somebody with lupus or something would have a positive result. Everybody would be very excited. But this one, you get the treponemal antibody test first. If you have a positive result and it is confirmed as positive, that means that the patient has active syphilis or they were treated before. So the thing to do is to ask if they were treated before, and if not, they do need to be treated. This one will stay positive for the rest of the patient's life, and I have so many patients that I order the wrong test, and then they see this one positive, and then such and such is cheating on me, and no, this is positive for the rest of your life. If you have a positive result, then you do a non-treponemal test. That kind of tells you the activity of the syphilis. If it's positive and they have a history of syphilis, you want to check to see if it's gone down. So if you have a patient that had a previous RPR of 1 to 32, you divide it by 4. And if it's less than 1 to 8, if it's 1 to 8, 1 to 4, 1 to 2, good, you're good to go. And that's actually good treatment. Sometimes if it can get stuck as a 1 to 2, 1 to 4, and if it's already been treated and it's come down by 4-fold, you're good to go. It's called serofast. And unfortunately, that's pretty common to people with HIV. It does not mean they still have syphilis. This is a reportable disease, so you can call up a health department of where a patient was, and they will have previous treatment information if you don't have it yourself. If you don't have any previous treatment history and you have an elevated lab test, then you will need to treat. So who do you need to do a lumbar puncture in? And these recommendations have changed over time. There's a lot of things with syphilis that are it's kind of waving hands, and they didn't really have good data, and they recommended doing all these things, and it's why do these things, and you don't really need it. Most patients do not need a lumbar puncture, but those that have neurologic signs or symptoms, and if you find, they had dementia, and I did a lumbar puncture, and it's totally normal, then it's not neurosyphilis. Tertiary syphilis, the people that have cardiovascular and gamma, you would also want to do a lumbar puncture to find out whether they have asymptomatic neurosyphilis. And then in certain people where their lab tests are not responding, you'd want to consider it in doing them. But most people do not need a lumbar puncture. Even those with very low CD4 count, high syphilis testing, you don't need to do it. So going back to the patient before, so he had multiple signs of syphilis. So he had secondary syphilis because he had the rash. He likely had meningitis because he had headaches. And he also had a red eye, which is ocular syphilis. So based on this, he has bought himself IV penicillin because he had ocular syphilis. Ocular syphilis can affect any portion of the eye, and uveitis is most common. If you have someone with new symptoms and new syphilis, you need to get them into the ophthalmology within a day or two. You need to treat them with IV penicillin. You can have a normal looking CSF, and you're supposed to. So if you just had somebody with only eye symptoms, you don't need a lumbar puncture. But if you're just like, oh, what is this going on? You can do a lumbar puncture. Otic syphilis is the same. If you have somebody with hearing symptoms and new syphilis, you need to get them treated urgently, and they can get hearing loss, vertigo. It can be on one or both sides. Back to this patient, they had a lumbar puncture and it showed 22 white blood cells, 90% lymphs. Protein was elevated and his VDRL was non-reactive. So does he have neurosyphilis? And sometimes this is a little difficult to tell because the lab results can be a little confusing. So the VDRL, one thing to know about it is not a very sensitive test. So it's only about 50% sensitive. So you're going to have to rely on other things. You can get a treponema-specific antibody test, but it takes a long time to come back because usually you have to send it out to Mayo or something like that. It has a very high sensitivity but lower specificity. So if you have somebody that are like, I really don't think they have neurosyphilis, but let's just get this test to rule it out, then you can use that. Usually the thing that you rely on is that if you see a number of white blood cells and you don't have an alternative diagnosis, then you probably need to treat for neurosyphilis. People with HIV can a lot of times have a few white blood cells in their CSF. So if you see a couple, but if it starts going higher numbers, then you're really stuck treating. If you see somebody just with the protein elevation alone, they probably don't have neurosyphilis. How do you treat neurosyphilis? It's IV penicillin. They say 10 to 14 days, but there's really nothing to say that it has to be 14. I don't know. Sometimes I smudge and if they're sicker, then I'll do 14. And then there used to be recommendations like consider benzathine penicillin afterwards, and there's really no data to support this practice. And as you're maybe aware, we've had a big shortage and it's not indicated. So not recommended at this time. So treatment of syphilis is you ask about neurologic symptoms, ocular or otic symptoms, then they would most likely need penicillin. If they just have primary syphilis, the chancre, the secondary syphilis, or if you're somebody who's regularly checking their labs and you have a lab test within a year that shows that they didn't have syphilis, then you just treat with one dose of benzathine penicillin. If you have latent syphilis or you don't know how long they have had syphilis or tertiary syphilis without neurosyphilis, you do 3 doses of benzathine penicillin for 3 weeks. If you, we have had some significant shortages of getting penicillin. Hopefully you're not having to deal with that right now because it was very challenging and we had to reserve the penicillin for the pregnant folks. And the patients don't take the doxycycline for a month is a big thing. And it's not as good as the penicillin. The penicillin is definitely the preferred drug. And of course, you can't use it in pregnant and pediatric patients if they are allergic and they need to have the penicillin. It is recommended to get an allergy consult and desensitize. So that's syphilis, and we'll do the questions at the end. This is another case. I'm seeing cases. This case was from July 22, but we are still seeing cases of this next infection. So this is a 50-year-old man. He has a history of well-controlled HIV. His immune system is in really good shape. And he presents with a rash. He has a history of hepatitis C, which was cured, but unfortunately, he developed hepatocellular carcinoma, and it was resected, and he's doing really well. But every few months, he goes to see the specialist. And they have this world-renowned specialist who feels like it's really important to shake people's hands. And he had this rash, and they didn't really deal with it at this specialist appointment, so he came to me a couple floors down afterward. And this was a picture of his rash here. Here's one picture. And then here's another picture of what's going on with his body. And then here's a close-up on one of the lesions. And, if you would say syphilis in this case, yes, that would definitely want to have that. It does look very viral, so herpes simplex virus and varicella virus also, but not usually. Varicella is usually a little more vesicular and more all over. Gonorrhea can also disseminate. And then, of course, this is a very classic picture of somebody with the infection called mpox, formerly known as a monkeypox. So the mpox rash can occur all over the body, particularly in the area of exposure. It's usually fewer in number than other infections. It starts with the macules and then it develops rapidly into the other stages and the pustular stage. And the one that we looked at was kind of this donut shaped with the umbilication, as you can see in the center there. And they can become necrotic and they're usually quite painful. What we want to see is eventually they crust over, and that's when there's a new layer of skin, and that means that they're not contagious. You can get symptoms of fever and other prodromal symptoms, but it may not occur with mpox or may not be present at all. Respiratory symptoms can rarely occur, but I haven't actually seen too many of those. And I want to give a trigger warning for people to show you a picture. It's pretty, I don't know, gross is coming to mind, but it's really tragic. So I'll show you the next page. In immunocompromised patients, this can cause very, very severe necrosis, and patients can even die from this infection. So in patients that have a weak immune system, particularly advanced HIV infection, this person had never been tested for HIV, and when he was found, he was diagnosed and his CD4 count was only 100. So they can progress very fast and very poorly. So what about the epidemiology of mpox in the United States? I still remember hearing in medical school about this outbreak of mpox associated with prairie dogs back from West Africa. And everybody thought it was kind of funny. And then every once in a while, I learned about in infectious disease fellowship that there's this mpox, and it's in people from Western and Africa. And actually, the year before our case was in 2022, we had one case of patient, and it was very novel, and we should have learned something. So 2022, it just exploded, and it happened. It spread to Europe and then the United States very quickly, and we had so many cases back then. And I guess you probably can't read these, but that really peaked in July 2022, which was incidentally the time I took over as the HIV clinic director here at Access. And it was a lot of work putting together the infectious disease protocols, the infection prevention, coming up with treatment protocols, and eventually vaccinations and public health efforts. But this is the kind of graph that you want to see with infectious disease. Look how it tapered off so nicely thanks to all the efforts from all different sorts of people. So that's wonderful. We still are seeing, though, low-level transmission of clade B, and everybody is worried about the upcoming festivals in the summer. There also is a new outbreak of clade. This is clade 2 that was in 2022. There's a clade 1 mpox that began in DRC, and it can be more severe, but we haven't so far, knock on wood, seen too much of clade 1 in the United States, but they're looking for it. How do you test for mpox? It's called the orthopox PCR testing. Another orthopox virus you should know about is smallpox. Basically, you kind of jab at the vesicle or the pustule and try to swab as much of that pus or liquid out of it, and then you send that out for testing. We're kind of spoiled in Texas, and Iowa is going to be kind of a pain if you have somebody with suspected mpox, because you have to talk to the state hygienic lab, I believe, to be able to get the lesions swabbed, and you have to get special kits for it. Treatment for mpox. So most patients, it's really awful and painful, but most patients recover within 2 to 4 weeks without giving them any special treatments. You just need to do pain management, and unfortunately, a lot of times they do get infected with like some cellulitis bacterial infections. So treatment directed towards Staph aureus. What about antiviral therapy? So there's this drug called tecovirimat, or TPOXX, that is used for treatment of smallpox and complications after smallpox vaccination. So that's FDA approved. And of course, smallpox being a bioterrorism agent, the CDC has this stockpile of it, and they released it under the EIA new drug IND protocol. It took me 4 hours to get this for a patient, and still this incredible amount of paperwork to be able to get it through this protocol, and it's very painful as a physician trying to get it. We do not like paperwork. Animal efficacy data showed survival benefit of animals with mpox over a placebo, but we still don't know this far into the epidemic whether it works in humans. There's still a trial called the STOMP trial currently conducted, and if you have any patients, I think the best route would be to contact the remote enrollment site at Rush University, which is the closest site to you. They do have virtual enrollment, so you can take like pictures and then send it to them, and then they'll send you drugs. So that's going to be a lot easier than trying to go to the CDC because it's just so painful in terms of the paperwork. In the patients that we had here that had severe disease, so if you had somebody that had a transplant or advanced HIV infection, there are some other drugs that we have used with various success. But we use those to get those drugs and also for the clinical consultation. We're best friends with the CDC right now. There is a vaccine, and there's indicated for certain people that are at risk for mpox infection. So if your patient is planning to travel to Dallas, Texas, and would be at risk for getting this infection, please vaccinate them before they come. And the person who shook the patient's hand did get the mpox vaccination, and it worked. So that's a good thing. The type of vaccination we have right now is it's called the Genius series. It is the vaccine for smallpox. As opposed to other smallpox vaccinations, this is not a live viral vaccine, so it can be given to people with severe immunocompromise, and the only contraindication is allergy to the vaccine. It can be given intradermally or subcutaneously. It's not 100% effective. It's probably about 70 to 80%, but again, it can reduce the severity of the disease. And the closest place to you that you can send your patient, they can call to get an appointment at the Polk County Health Department. And one last case. This is occurred in 2012, and it left an impression on me, but unfortunately we see this case all the time here in Dallas. So this was a woman with no past medical history, 50 years old, presents with shortness of breath on exertion. Symptoms have been present for 6 weeks and just gradually getting worse. She has a dry cough, no fever, chills. She had been admitted to two hospitals with pneumonia and treated with antibiotics for bacterial infections, but her symptoms just got worse and worse. On admission, she was quite ill. She was tachycardic, breathing very fast, and was hypoxemic. She had thrush on exam, and she had crackles. And this was her chest X-ray, and she required intubation for respiratory distress, and it has this bilateral diffuse ground glass opacities. And so at Parkland Hospital, we do universal screening for everybody who comes in the ER for whatever reason, and so that was where we made the diagnosis of HIV. She had gone to these multiple other hospitals, and they had not tested her for HIV, and her CD4 count was quite low. And so you can see that knowing that information that she had HIV and AIDS really shifts your differential diagnosis and really makes it very, very broad. And the emphasis is not to go through the differential diagnosis because fortunately you don't see this too often in Iowa, but pneumocystis jirovecii is the most common cause of this clinical presentation like that. And that's what she turned out to have. You can diagnose it through sputum testing or a test called the Fungitel that is very sensitive for fungal infections. And the management is trimethoprimsol methoxazole with steroids. So you're probably all aware of, ever since 2006, it's recommended for everyone ages 13 to 64 to get tested at least once as part of routine healthcare. And people with certain risk factors should get more often, but and you're probably aware of those. But we need to not, make assumptions on who has HIV. We need to really, this test costs $30, and if you use it very diffusely and you don't say single people out and they say you need to get an HIV test, people are going to be more likely to get it, and we'll diagnose people sooner. So wanted to update you a little bit about HIV treatment and all the missed opportunities we had with this patient to treat her before she got sick and even to prevent HIV. And we've come so far, even in the past 10 to 15 years with HIV treatment. So, there's still no cure for HIV. You still have to take medications. But nowadays, the life expectancy of somebody who's diagnosed with HIV who stays on treatment is basically the same as somebody who's not diagnosed with HIV. And the vast majority of our patients are taking, instead of those handful of pills that they used to take, a single tablet regimen. It contains 2 to 3 medications within it, but it's just one pill once a day. It's extremely effective if you take it, and very few side effects, and the patients just do really well. The 2 first-line agents that are most commonly prescribed in the United States now are Biktarvy and Dovato, and they're made of an integrase inhibitor and some drugs that are active against the reverse transcriptase enzyme. As you can see, at Hy-Vee, even with a coupon, it is extremely expensive, so you have to have some sort of insurance coverage or send your patients to the Ryan White Clinic where they can get the medications for free. But they're very, very effective. You may not be aware, but something that is very exciting is the advent of long-acting injectable therapy for people with HIV. And it's kind of similar to those like contraceptive, like all the options that we have available. So instead of taking a pill once a day, you get an injection. You get 2 drugs. One goes in each butt cheek. One gets cabotegravir, which is an integrase inhibitor, and rilpivirine, which is a non-nucleoside reverse transcriptase inhibitor. And those last for about 2 months. They last for 2 months. And so they don't have to take a pill every day. And many patients say, like, I'm not reminded of my diagnosis, and then forgetting to take the medicine is also a big problem. It really doesn't have a lot of side effects, but it's a large volume of patients have. So pretty much everybody gets like this injection site. But when you ask patients like, ooh, do you want to stop the medication and go back to pills? They're like, no, I love not having to take a medicine. So this is not the drug for everybody. It does not treat hepatitis B, whereas some of the other medications do, and for people with resistance mutations. And it's also, unfortunately, not for the person that's like a drive-by injection and you never see them again. What it does is it has the levels in the body and they're therapeutic for a few months, and then the levels are going to start dropping. So it's really important that people stay on time for those injections, because otherwise the drug levels will drop, and not only will the drug stop working, but they can develop resistance to the medication. So we're not using this in everybody, but this is just the first long-acting injectable for HIV treatment, and we're looking forward to more. Another missed opportunity for this particular patient was for pre-exposure prophylaxis. So for those who aren't aware of it, there's now a drug that you can give people that can prevent HIV. So it's people who do not have HIV but are at risk for obtaining it. And these are the current recommendations from the CDC to discuss with patients. But we know that we're not, even when you use these particular criteria, you're missing people. So, just keep having the conversation, get the education out there, and, make sure that people who need the coverage are covered. So those that, we have a pop-up that if somebody was diagnosed with any sort of sexually transmitted infection, it's like, whoa, this person's at risk for getting HIV, and you should suggest PrEP. It's also indicated for people who use injection drugs. So what options do we have for pre-exposure prophylaxis in the United States that are FDA approved? Well, we've had Truvada for a while. That is $26 with a coupon. But then there's also Descovy. That's a new and improved version of the Truvada that has a little bit of fewer side effects. It's only was studied in people who were assigned male at birth. It probably works just fine, but we don't have the data for use in women. But we also have, I told you about the Cabenuva has one of those drugs as cabotegravir. You don't give a full regimen for HIV, but if you just give the cabotegravir, you have long-acting protection lasting 1 to 2 months. And the efficacy actually of all of these is over 90% if the patient takes the medication. And of course, it's easier to adhere to a once every 2 months injection rather than a daily medication. Coming attractions for pre-exposure prophylaxis. This is a picture of the HIV structure. And if you remember, there's a little capsid that keeps everything all together in the middle of the cell. And there's a new drug that's approved to target that part of the life cycle of HIV. And so we have it for our patients with HIV for multi-drug resistant HIV. Unfortunately, we don't have any other drugs that last for 6 months, but it's a 6-month cutaneous injection. But it's being used for pre-exposure prophylaxis. So they just get this one injection of lenacapavir once every 6 months. And they just stopped just a few days ago this trial for use in women. And they found 100%, 0 cases of HIV in the group treated with lenacapavir. So the study was stopped early. There's another study going on in men have sex with men and transgender people, but this is just really incredible news. And not to say that Truvada is not a great PrEP drug, it's just that human nature, we just forget to take our medications every day. And if you don't, you're getting at risk for HIV. So even though we don't have a cure or a vaccine for HIV, we have the tools to end it. And this was the ending the epidemic that was proposed by President Trump last. And this is his goal, is to end HIV. And I sincerely hope he gets his wish. The two tools that we have for ending the epidemic that are the most powerful are treatment as prevention. So in my patients that have an undetectable viral load, they cannot pass HIV on to another person. So that's incredibly valuable prevention strategy. And then there's also pre-exposure prophylaxis for patients who don't have HIV. And then, I go through like being optimistic and pessimistic about this. We have all these tools, but implementation is really, really hard, especially in places like Dallas. These medications are very expensive. It's going to be really hard to reach the vulnerable populations. I've been very shocked about the lack of education here in terms of knowledge about HIV and how to prevent it. And then there's all these other things that our country and the people of Texas are having to deal with. But we need to look to Iowa to get some ideas because Iowa has the best rates of viral suppression in the entire United States, significantly better than anywhere else. So we just need to use the lessons that we've learned from Iowa about collaboration, education, and of course, the best medical care in the country. So, any questions?
Your medical bill.
I have a question.
Yes.
What do you think the cause of the increase in syphilis is?
That's a good question. I think, my short answer is probably the internet. So I think there's also a lot of complacency about, syphilis. People don't realize that it is an issue and that it's affecting groups that don't necessarily think of themselves at risk for syphilis. So all of these things kind of combined together is really increasing the cases everywhere. I did forget to mention there is actually something called doxytep, so doxycycline prophylaxis that you can give to patients that are at high risk for syphilis. So they take doxycycline as needed kind of around the time, and that can actually really cut down on syphilis cases. That's something we've been rolling out here in Dallas.
Question.
Go ahead, Dr. Bennett. They can hear you. There's microphones in the ceiling.
Has there been a change in routine screening for syphilis over the decades?
I haven't really seen anything. It's definitely recommended in folks that have HIV. I haven't seen a recommendation yet for a general population for syphilis. I think we're probably heading towards that. It's definitely recommended in pregnant women to prevent congenital syphilis. But sometimes the problem here is that people present very late to prenatal care and there's not enough time.
How did the antivirals work?
For
The early one, you cited the drug that was used.
For HIV or for?
No, for influenza.
For influenza, these are neuraminidase inhibitors. So remember the last part of the life cycle of influenza is that it kind of buds from the cell, and the neuraminidase inhibitor chops that, or the neuraminidase enzyme chops it so it can move off and infect other cells, but the neuraminidase inhibitors block that step, so it's just kind of stuck. So it doesn't spread to other cells.
Thank you.
Yeah, one more question about syphilis. Its advanced stages, Does it take on the characteristics of an autoimmune disease?
I mean, in some ways it does. You get a lot of inflammation particularly in cardiovascular disease. And so you get like an aortitis, an exuberant inflammatory response. So people can end up with aortitis and strokes from that.
And do steroids have a role to play in treatment?
There really aren't any data about using steroids in syphilis. Some people do it, especially for eye disease, but I don't know that I would recommend. I think just the penicillin alone is what you really need.
All right. Thank you, Dr. Kitchell. Not seeing any other questions in the audience right now.
What is the